So I'm going to talk tonight about managing nasal obstruction. And when I gave my title to Allergens, I said, you're going to speak to a group of ENT surgeons who know how to create space in the nose, but often don't attend well enough, I think, to the underlying allergic drive. And so I said, they don't need a lecture in rhinitis. They all know what's going on there. What I think needs to happen is we need to integrate allergy care into how we utilize surgery in ENT. And so really the concept here is AIT as a way in which you can guarantee a much better outcome from your surgical interventions. So tonight I'm going to talk about a little bit about the symptoms of allergic rhinitis. I'm going to talk about the impact of turbinate reduction on nasal obstruction and other symptoms. And then I'm going to use a handful of case studies to talk about how I use allergy immunotherapy, or AIT, in managing patients who come to me with nasal blockage. Because I really do think it's actually the key to getting patients right. I don't see myself as being a better turbinate surgery surgeon than David Pohl or Michael. I think we actually all probably perform a very nice turbinate reduction. The success, I think, in many patients' journey is how you manage their allergy alongside of all of that. Now, it's very important to understand that allergic rhinitis is super common. You know, it's highly underrecognized. I even saw a person today who told me, oh, I had a blood test a long time ago, I'm not allergic. And then she had the most allergic nose, highly reactive on skin test to dust mite, but really didn't recognize that just because she didn't have itch and sneeze that she wasn't allergic. That highlights this statistic that actually a large proportion of patients actually go under-recognized before they actually see someone who deals with their allergy. And it's very important, the minute someone gives you a history of having childhood asthma, I'd be careful here to saying not any asthma, but childhood asthma, that they almost certainly have an allergy. And that's because when it comes to allergic patients, they often follow this phenomenon of what we call the atopic march. They're kids who have atopic dermatitis, food allergy when they're younger, and they go on and develop asthma, and they get these symptoms that start at the ages of sort of 5 to 12, and they carry on throughout their sort of teenage years. If I take out the curves and just show you where the allergic rhinitis curve is, this is very important. It's one of the reasons why we rarely do turbinate surgery in kids younger than about 5 to 7. It's really just not a feature in the nose. Most kids haven't had a chance to develop turbinate hypertrophy at this stage. And actually it's a little bit tricky to sort out perhaps adenoiditis, chronic adenoid enlargement, colds, viruses, and allergy before that age. And so you really only see allergic rhinitis becoming a feature in that sort of 7 to 12 age group. You can see that's the sort of the influx of the curve there. When it comes to symptoms, as surgeons, we become, I think, a little bit over-fixated on nasal obstruction and sleep. There's no doubt that that's a big part of what we see as patients who present to ENT surgeons. But really, there's a whole range of other symptoms. And if you look here on the screen, you can see that although obstruction of sleep do rank very highly, in the top 6, all of which are highly prevalent in these patients, is everything from cough, sneezing, conjunctival reactivity, other discharge, and there's a whole range of other symptoms. Fatigue is a big one. I'm not going to talk about it much in tonight's talk, but fatigue and productivity and concentration issues are a huge part. In fact, actually, studies have been done to show that adults during their allergic season have impaired driving performance compared to adults outside their allergic season. And these are studies done on sort of velodromes and the same sort of tests they use for blood alcohol level. There's studies to show that children who are allergic underperform scholastically compared to their non-allergic peers as a group. And that's very important. And that study's been repeated, not just in England, but in Thailand as well. And I think when you see cross-cultural studies being repeated, you can probably bet that that effect is real. But one thing that is true, and any self-respecting ENT surgeon who sees their patients beyond 6 weeks will know that turbinate surgery is one of those procedures we do in ENT that where patients either love us or hate us, and it's often related to their expectations. And there's no such thing as turbinate hypertrophy as a diagnosis. The diagnosis there has to be a reason why that person's gotten turbinate hypertrophy. There are non-allergy reasons why people get congested noses, but in those people who have allergy, if you look at the effect in this study here of radiofrequency turbinate reduction, they looked at the return of symptoms for non-allergic rhinitis patients. And look, there's no doubt that patients do benefit, at least in the short term, from these treatments, but the effect is lost unless the underlying condition is treated. And that actually is worse for allergic patients. Allergy patients very quickly go downhill and return to their pre-surgical allergic state if it's not managed. And so, under managing the allergy, the surgeon should be very wary of how that's going to impact their long-term surgical results. Now, that was one study looking at radiofrequency, but I want to just point to you a couple of recent studies in literature. This one here looked at septoplasty turbinate reduction in people with allergic rhinitis. Actually, the benefit here, they only followed these patients out for six months, and they looked at allergic and non-allergic patients. And very similar to the radiofrequency study we just saw, they do poorer. The allergic patients constantly report a worse RQLQ, or quality of life score. And at 6 months follow-up only, the non-allergics and allergics have already separated themselves in terms of quality of life difference. This study looked at septoplasty. This is septoplasty with turbinate surgery, short and delayed. And a fascinating part of this time is they showed that the effect of septal and turbinate surgery declined over time. And interestingly, it declined in the younger age group. And I think really that's reflective of patients who are not just allergic, but have active allergy still. So there's lots of patients who say, oh yeah, I get a bit of hay fever and they're 50. But really they're describing now in their 50s a very mild mechanism. But when they were younger, it was probably much more active. And so young people in particular are your target group for those who have active allergy and should be considered for treatment. Finally here, this is a great one. This is one of those studies, I always think when you look in the literature, if you look at some of the data around studies where they're not actually, the focus isn't about the success of the turbinate surgery, true data really comes out. So this was a study in which people were trying to validate the NOSE, the nose questionnaire, in pediatric patients. And in doing so, they showed that at 8 weeks follow-up only, 55% of patients of these allergic rhinitis children that had a turbinate surgery were still using regular pharmacotherapy every day to control symptoms, only at 8 weeks out from the surgery. So a great study to show that even though we think turbinate surgery creates a great benefit, even in this allergic rhinitis patient group, at 8 weeks, more than half are still needing to use pharmacotherapy to get symptom relief. And it's not surprising. We have a look at adults here. If you look at the range of symptoms, it's not just blockage. It's a whole lot of other things. And this is going to bring me to my first study. So this is, Demoli is a recent study on house dust mite immunotherapy. Like many house dust mite immunotherapy studies, they're randomized controlled, placebo indexed. This is a study that looked at patients over a 12-month period, placebo versus house dust mite, AIT. And it really showed that compared to placebo, there's always some sort of placebo effect, but compared to placebo, there's a significant reduction, not just in nasal blockage, but all of those other symptoms that patients complain about, from rhinorrhea, watery nose, itchiness, sneeziness. So let me bring myself to our first case study. Now, when I show videos here, there's a couple of things I want to be important. We'll touch on this. This is a normal nose. So someone who has non-allergic rhinitis, if you decongest them, their nose will look like this. The lining's thin, smooth, there's no cobblestoning, there's no edema, there's no hypertrophy. You can see that the middle turbinate's not making contact with anything. The inferior turbinate too, there's what we call the armpit. You can actually see into that inferior meatus. This is an allergic nose. I think I was taught when I was a trainee that you couldn't tell an allergic nose from a non-allergic nose, and there's very good criteria now. This is someone who's got what's called the middle turbinate contact point. between the middle turbinate and the lateral nasal wall. And anteriorly, they've got this sticky mucus. It's cobblestoned. There's contact points here. This is a typical sort of allergic nose. And we'll touch on this again. You've got to be able to read rhinomanometry very briefly. Now, this is what's called a pressure and flow curve for my talk. When the sticks are vertical, so this is someone breathing in. You can see the expiration in the top left-hand corner and the inspiration on the left-hand side in the bottom right-hand corner. And you get the curve on the other side is expiration, inspiration. And these two curves dictate the amount of flow you have for pressure. So if you've got a lot of flow for pressure, the sticks are vertical. And if you're blocked, the amount of flow you have for pressure is much less and they're much more horizontal. So let's have a look, because I'm going to show this in the context of our patients. The first lady is a 25-year-old. She's a student teacher, IBS, tonsils, adenoids, like many children have an allergy. They have some sort of treatment by an ENT when they're younger. She describes her symptoms as since birth. She gets cycling congestion, that watery discharge, itch, sneeze. There's no barosinusitis. I always look for barosinusitis because I think when patients get that mucosal thickening like the video I showed you, one of the early symptoms they get is barosinusitis, and that's a sign of a bit of sinus dysfunction. It's bilateral. It's a really important thing. Bilateral and synchronous. And she's used intranasal corticosteroids and antihistamines a lot, but she calls them minimally effective. She describes childhood asthma. It's much, much better now as an adult. She gets lots of conjunctival symptoms and no eczema. She's tried all of these medications and on them regularly. And when you measure her nose, this is actually her nasal airway. So this patient, she can barely get flow through the machine when she's trying. And there's sort of patients, you strap them up to the machine, they almost feel like they're suffocating. But surprisingly, when you look in her nose, it's not as bad as you think. And I'm going to show you her nose down the track. Now, you might look on this side and think, okay, it looks a bit narrow. Maybe this side, maybe there's a slight septal deviation, hard to say. This is actually after a spray too. And when we do her allergy testing, she is really straightforward. She's not polysensitized. If you have a look here, she has got a very strong positive reaction to house dust mite. That's the second line there. You can see she's got a really strong house dust mite reaction. She was actually taking antihistamines at the time of this test. And so even her positive control is positive at sort of a 6 millimeter wheel, but it's actually not so impressive. This is her CT scan. So she doesn't have barosinusitis, so it's not surprising that the sinus scans look pretty normal. She's post-decongestion at this point. You might say, oh, there's a subtle septal deviation, but very minimal, very minimal. So in this patient here, who's got those conjunctival reactivity symptoms, itch, sneeze, watery discharge, it's been on pharmacotherapy, it's a history of childhood asthma. To me, the first thing I don't think of septal and turbinate surgery for her. I just think that she's a great candidate for immunotherapy. And one of the big advances, I think, in immunotherapy, especially for ENT surgeons, is that we don't have to order it in. So there's no longer a sort of sublingual drops that have to be patient-specific formulated now. For common things, especially dust mite and temperate grasses, we have a couple of options. So for kids over 5 years, and you can see why 5 years has been picked by the World Health Organization too, it's that issue about diagnosis. It's very hard to prick an allergic patient before then. But for patients 5 years and over, the commonest thing is house dust mite for perennial allergens. And Actair has a small escalation dose and then very quickly into a standard dose. And there is a temperate grass equivalent. I think in Australia, it's much harder to pick out temperate grass patients clinically because our temperate grass season is so long, not like in Northern Europe where people will give very discrete seasonal reactivity. But you just still do see it. And so there are two options here of managing these patients. And the way that immunotherapy works is that you've got to get them through this phase, which we call the escalation phase. When you first start patients on immunotherapy, they will get a local reaction, and they will often say that it feels like my allergies are playing up on me. They've got to be prepared for this, and they've got to understand that taking regular antihistamines where they didn't before might be part of that initial journey. But very quickly, between about 2 to 6 months, that disappears. And when it disappears, this is when they get then symptom relief. There's not a single allergy patient that should be left on immunotherapy more than 6 months without demonstrating clear benefit. And then how long they need to be on it is variable, and we'll talk about that. There's studies to show that as early as 12 months, you'll have prolonged immunoconversion where patients lose their allergic drive. And probably somewhere between 12 and 36 months should be the framework in which many patients see themselves. But they don't have to wait that long. It all happens in the first 6 to 12 months on treatment. So let's have a look at her. This is how she started. I gave her immunotherapy, and only a short period later, this is now her nasal airflow. Gone is that, right-sided supposed septal deviation she had. And then we left her on it, and this is her now. For those of you who aren't familiar with immunotherapy, you'll see that at 150 pascals, at 0.125, it's almost as good as a post-surgical outcome. So she's just on immunotherapy alone. Now, when you look in her nose, this is what you see. So this is her nose after the first lot of treatment. You can actually see, it's amazing how her septal deviation, maybe there's a bit of a high septal deviation, but it's not as bad as you think it is, right? I think if someone had a septoplasty and came to me with that, I'd be like, that's a pretty reasonable septoplasty result, So it's actually not as bad once the congestion goes, but you can see that edema. See how the middle turbinate touches the lateral wall. Gone is the middle meatus. There's middle turbinate edema. That is referred to as the middle turbinate contact point. And I just want to touch on this because identifying the problem is really important. So this is a study that's just been published, actually. It got published as an abstract in respirology, but now as a publication in rhinology. This was a study by one of our researchers that talked about, in A here, you can see the concept of middle turbinate edema, where you get the contact point between the middle turbinate and lateral nasal wall. B is a case of what's called polypoid edema that you'll see on the middle turbinate. This is another incredibly strong marker of inhalant allergy. Sticky secretions in in C. And in D is an inferior turbinate. And if you said to me, Richard, I was taught that the Mulberry end of an inferior turbinate is the gold standard of seeing allergy. That's not actually true, Studies on adults especially have shown that actually having a sort of a chunky back end it may be a sign of rhinitis, but it's not a sign of allergy. And actually, a stronger indication of allergy is losing what we call the armpit. So the inferior meatus is disappeared, and the tissues are sitting like a pair of bum cheeks in the inferior meatus. And that's a great sign. And so one of the studies, there's a couple studies in each of these different diagnostic features of allergy. And this is an ROC curve. So this is a receiver-operated curve for these endoscopic features of allergy. And the blue line is middle turbinate changes. And so actually, if a piece of advice from someone who's in this field, I would say it's not the inferior turbinate that you should be looking at when you want to know whether or not someone's got allergy. It's actually changes to the middle turbinate are far more accurate. Actually, and you can see down there, posterior turbinate hypertrophy is the pink line. It's actually only one study in that from the literature, and it sits on the 45, which is the no difference. The test, it doesn't dictate the outcome there. Here's our lady. She's approaching 3 years into immunotherapy now. You can see what's happened on the left-hand side. That jelly edema has actually gotten better. It doesn't completely resolve. Here's her supposed side of her septal deviation that we never fixed. Actually pretty good. And here's the other side there. You could see a little bit of the crest, in fairness to the radiologist who called it a septal deviation. But this is her middle turbinate change over time. And I haven't given her any corticosteroids. There's no sprays. I told her to forget, don't worry about your treatment that you've been using. I said, just focus on getting rid of the allergy. And so not only can allergy, it doesn't fully get rid of all the remodeling change. And I think that's a really important concept for my next case. But you can see on allergy immunotherapy alone, it's quite dramatic. When does that happen? 12 months on treatment is when you see a very clear symptom reduction. And And that will be maintained in the second year off treatment. So some patients in the Bergman study, just one 12-month period on treatment is enough to give them prolonged benefit when they come off treatment. I think when I was a trainee, I was told that somehow all allergy treatments, allergy patients needed 5 years of therapy, otherwise it was just going to fail. And I think that was perhaps a corporate-pushed approach. I think when studies have come out, it's actually quite clear that some patients convert very early to long-term remission or conversion from their allergy treatment. And in studies that have looked at what happens in the first and then second year on allergy treatment, this is one here. This graph on the left-hand side shows, I guess, the severity distribution of symptoms, how it changes into the first and second year. But I think probably better is to look at the bar graph on the right, because the magic all happens in the first year. There are incremental changes, and maybe we can talk about how do I decide when someone should give up after a year or 2 years or 3. But there are some incremental changes, but amazingly, most of the benefit comes in the first 12 months. And we can talk about that later on. When it comes to success here then, apart from picking the right person, you've got to have someone who's got an inhalant allergy. It does slightly depend on making sure you've given the patient enough of the protein and long enough to get this benefit. And at least a 12-month period, especially for house dust mite, is the sort of the golden standard of what you should be aiming for. And when I say at least. So when you sit down with the patients and you say, how long am I going to be on it? You say, we're going to do at least 12 months. The reality is if you've done it right and picked it right, you don't have to motivate them beyond the 12 months. They'll be motivated at that point on the benefit. So what's the treatment paradigm? Who should we be cautious in starting? So here's a young girl who's come to me. She's on an inhaler. She's already using maximal medical therapy. You just don't want to start someone on immunotherapy who's got unstable asthma. So if they're a bit bronchospastic and wheeze, they've never been on an inhaler, someone who's got an FEV of less than 70% of predicted is not a good person to start. You might want to start them on an inhaler before you start them on allergy treatment. That's very uncommon though. I think most people are given an inhaler by the GP. You don't need to send them to a respiratory doctor. If they really simply have untreated asthma, you just give them a Symbicort inhaler. That's what the GPs do. When do we do a turbinate reduction? I was discussing this with David Pohl before. I really do bring patients back 3 to 6 months in to have this discussion about, is their nasal blockage being relieved? You don't want to leave a patient on immunotherapy floundering with nasal blockage and their reference point as to is everything working purely based on whether their blockage is resolved. So that, and we'll talk about this in the next case. Pharmacotherapy options. I think I was speaking to someone tonight. I don't talk about pharmacotherapy anymore to patients. They've got it. They've been told it all by GPs and everything else. When patients come and see, I have a long-term vision about what we're going to do about their allergy and their nasal airway. I sometimes will discuss pharmacotherapy in the setting of acute flares. And in that case, I get them to use off-label uses of Dymista, 2 sprays 6 times a day for 3 to 5 days to help settle down a viral-induced flare of their underlying allergy. And then, of course, you've been able to see the effect of allergic inflammation and its reversal by AIT. Let's talk about case 2. Case 2 is a 48-year-old male. He's a non-smoker, no medications, pretty simple. He's had 30 years, like all my life, of sinus. Like how the public use the word sinus, allergy, hay fever, blockage, congestion, they're all interchangeable. But clearly when you listen to his sinus story, it's blockage, watery nose, his smell is intact. If I can say one thing, the minute someone tells you the smell is intact and it's bilateral, they've got an allergy. It's not sinus disease. Their smell's intact. Itch and sneeze symptoms. Once again, this is very important for this patient. No barosinusitis either. His treatment is oxymetazoline. So he's used decongestant, he's used antihistamines and intranasal corticosteroids, and I'm sure everyone here will relate to that. Patient comes into at this point now, he's just given up with everything, and he's just using oxymetazoline all the time. And not surprising, this is his flow curve, and you have to forgive my scientist who's tried very hard to take a measurement here, and you can see it's all over the shop. He's got a nose full of secretions, the sidewall sucking down onto it, and this is what it looks like. You can see very blocked, very congested, huge amount of turbinate hypertrophy. He's got that ridge between the turbinate and lateral nasal wall. He's lost his armpit down below. And so he's got hypertrophy. You don't get that look. This is my other thing I would say. If you are an abuser of oxymetazoline, your nose never looks like this. These are allergy changes. People who abuse oxymetazoline, when you spray their nose and decongest them, they look like a beautiful, nice, normal nose. So people who just had a viral event one day and got into a rhinitis medicamentosa, they have a normal looking nose. They won't have middle turbinate hypertrophy. They won't have this weird hypertrophic thickened lining. Only allergy and maybe cocaine or drug use, recreational drug use, will create this sort of thickened tissue response. And of course, when we do his allergy testing, he's got this pattern here. He's a little bit polysensitized, molds, dust mite. And when you have a chat with him, he doesn't own a cat. So he's really got indoor allergy, perennial allergy, and he's got very, as you can see here, his flare and wheal response for his dust mite was pretty significant. When you do a CT scan, he's got this. Now you can bet the PRP radiologist called it extensive pansinusitis. But anyone who doesn't know this picture, this is CCAD, or the central compartment atopic disease. It's this central thickening, and you can imagine that this person just has really thickened turbinates where the peripheral sinuses are all black still, the black halo sign it's sometimes referred to. This is central compartment atopic sinus disease, and it's not a sinus change, it is essentially an exuberant allergy response. So this guy, we start on allergy treatment, but I tell him, we're starting allergy treatment now, but I'm going to do your turbinate and septal surgery in 3 months. And so we just book him in for this surgery. I dangle it out there like a carrot. He's going to get it to stay with the program. And this is what his airway looks like a year after his septal turbinate surgery. And you can see I've even trimmed off, the jelly-like change of his middle turbinate. I don't always think you need to open the sinuses in these patients. He's normalized his sinus scan. He still has a little bit of edema there of the superior turbinate. You can see that jelly-like edema. But essentially, he's gone from that terrible nose to a really healthy nose. And it's not really my surgery that did it. I just helped him break the blockage cycle. It's really his allergy treatment. Now, that brings me to a slide that, when you read up about immunotherapy, there's a lot of discussion about patient education, making sure they know what to expect, how long to expect it. And while they're very, very important things to make sure patients are well educated about their immunotherapy, it's not the key to success as an ENT surgeon. The key to success is the timing of the turbinate surgery, because you can't let that patient feel like their blockage is not resolved while they're on the allergy treatment. You can't let them get that sense. You can't let them become demotivated because their reference point as to is my treatment working or not, their nasal blockage, and it hasn't resolved. Now, it just brings me to a little study I want to touch on, because we know that patients who have nasal blockage won't get better on AIT alone, that prolonged exposure causes refractory blockage, permanent turbinate enlargement does occur, and that immunotherapy, while it stops the process that forms the turbinate hypertrophy, it doesn't unwind it. It doesn't completely resolve. And even that middle turbinate edema change I showed you actually is still there like 3 years later. That middle turbinate is still a bit chunky in case 1. And one of the features of a Cochrane review looking at AIT was actually exploring the whole idea of how does AIT interact with turbinate surgery. And so this is Raquel, our scientist who works in our group. We with a research student, I think it was last year, we did a retrospective cohort looking at patients who'd had AIT with and without turbinate surgery to look at what are the features between them. And so there was 118 patients in this study. The majority actually had AIT alone, but a large proportion had AIT with inferior turbinate reduction. A really key factor here was that they were patients who complained of a major focus of their presentation was nasal blockage. So they were patients who had nasal obstruction as their clear feature. And when you look at their outcomes here, that they did, in terms of their intervention, they all did it. Well, you forget the p-value here because it's between all 3 groups, but they had improvements on all three outcomes. And when you compare the 2 groups, this is the main slide. Those who had an inferior turbinate reduction generally said that they were less likely to fall into a high category of nasal obstruction. They had a slightly greater improvement in nasal peak and respiratory flow, and they actually had a less airway resistance or a lower total nasal airway rhinomanometry. And this is a very important thing, that you can't cure some turbinate hypertrophy and nasal obstruction with AIT alone, but the combination together, especially in those patients who have nasal blockage as one of their major features, is highly effective. So if you said to me, when do I consider the role of inferior turbinate reduction in AIT? There's no doubt that patients who come to me with this remodeling change, where they've lost the armpit, they've got the inferior meatus has disappeared, they've got middle turbinate edema, polypoid change, I certainly talk to those patients early on that they're probably going to need a reduction. I think 2 to 3 months after the surgery is ideal, and I really avoid starting the AIT in what I call is the honeymoon phase after surgery. So all surgeons will know that when they start their AIT, they start their surgery, that the patients for about 6 months after their surgery will say, I really feel like it's fantastic, my allergies are gone, I'm not sneezing anymore. And then you can guarantee by 6 to 12 months later, those allergic symptoms have started to return. And so if I had to plot it out against one of the charts that we had, I would say that the time you have to be cautious about starting AIT is somewhere here. After you've done a turbinate operation, in that first 6 to 12 months, when they feel like you've magically cured them from all their allergies with just this simple reduction of the surgery, it's false. It's a honeymoon, because the trauma of the surgery suppresses the type 2 allergic drive. The trauma of the surgery gets rid of their nasal hyper-responsiveness and their nasal reactivity for a little while, and then it all returns. And the last thing you want to be doing is on the back foot as a surgeon with an unhappy patient 12 months later. I'm congested, I'm blocked, it's up here now, doctor, I'm back to how I was, it hasn't worked. And so I think so the time to start it, in my opinion, is beforehand, and it gets the patients to buy in. So although we talk about what do we do in terms of motivating factors, it is important to talk to patients about it, because a lot of patients who have started on AIT don't recall the fact that they weren't informed that they're going to go through an escalation phase, how long it should take, the fact that their allergy symptoms might not get worse. I mean, these are all things that are often mentioned, but I think it's really important to talk to patients about when you're going to relieve their blockage as part of it. Let's talk, and this issue about preferences up here, 33% were not asked about their preferences. I think that really resolves around this idea of, like, how am I going to get rid of my nasal blockage, And I think waiting 12 months to get rid of your nasal blockage, hoping that AIT will work, especially after 3 to 6 months, is unlikely to help. But what you don't want to have is this guy I'm going to show you now. So the next patient was a patient of mine who had a bit of central compartment atopic sinus disease as well, so he's had allergy. He's my patient. I did a septal turbinate surgery. Here he is 8 years on. He came back and saw me. Oh, the allergy treatment, no, I didn't start that. I didn't start that post-op. Look at his sinus cavity. He's got a completely normal sinus cavity, but look where his jelly-like changes are. All of the turbinate has become bulky and jelly-like and swollen again. And this is a patient who's essentially had a septal turbinate and sinus procedure by me, and 8 years on has never had their allergy treated. And so they've got all their symptoms back. I can tell you right now, that patient had every symptom back. The jelly-like swelling of their middle turbinate is not the problem, it's the untreated allergy. The swelling of the turbinate is a feature of you haven't treated the allergy, and therefore the tissues have continued to remodel. Let's talk about case number 3 as our last case. This is an 18-year-old female. Now, she's only recently in my care, but I saw her recently and I threw her in as a case because I think she's fascinating. She's student. Admittedly, anyone who's 18, female and on antidepressants is a bit of a worry, She describes having allergy symptoms. She's definitely got that history, once again, of a person who's had a childhood interaction with an ENT surgeon, grommets, adenoids. And this raises this study that I think is really important. This European group came up and they looked at children average of 5 years, more than half were atopic and had allergic rhinitis. And they actually used this study to show, it was one of the studies in our systematic review looking at allergy features. The middle turbinate contact point that I showed you, where the middle turbinate gets swollen and obliterates the middle meatus, that has an odds ratio of 9 as a predictive value of allergy. Large adenoid score actually had an odds ratio of 3 to predict allergy, and then some of the usual players, family history, asthma, comorbidity. So that's very, very important, that any children that present with these sort of allergic symptoms, nasal congestion, have a history of adenoid grommets, super high. More than half of them are allergic when they present. So she had a little bit of Nasonex allergy, and she certainly got some effect from them, and she uses antihistamines intermittently. I think this is a great scan. She came to me telling me, despite this history of having this congested nose, fluctuating from side to side, the conjunctival symptoms, the watery nose, she was told that I have a right septal deviation. I've been told that. And the CT scan report says it. So guys, this is the scan when you first look at it. Who would think that's a septal deviation? There's no doubt that the airspace on the right-hand side is narrow. I don't doubt that. You can clearly see there's mucosal thickening on that side. That's the right-hand side on the day of her CT scan she had done elsewhere. This is her rhinomanometry on the day she saw me. It's not her right that's blocked. It's now her left. And she couldn't breathe through her left-hand side. And when you look in her nose, this is her nose. She doesn't have terrible hypertrophic changes. You can see her armpit there. So you can see into the inferior meatus. I had a quick look down. I did on the other side to make sure her turbinectomy or adenoidectomy looked good, which it did. But that's her left-hand side. Here's her right-hand side of her septal deviation. What do you think about the septal deviation? It's not much of a septal deviation, even though the radiologist and the previous specialist said that that was going on. But when you do a skin prick test, this is her, the top right-hand corner is her positive control, so histamine. Top left, you can't see it, it's the glycerin negative control. And the very first one down there is DP as a dust mite. So she's got really quite a strong wheel to that. Go back to her nasal examination. Post-decongestion, I actually look at her nose. If anything, like my first patient, I'd call the septum ever so slightly anteriorly off to the left. Maybe at the high end, it's off to the right, but you know, oh my gosh, as far as natural septums go, it's about as good as they get. And if you have a look down her nose, this is her CT scan as we go down. I don't blame the radiologist for calling it a septal deviation, but I ain't really. This is just, look at the congestion there with all the turbinates touching each other. And then she's got sort of a big chunky sort of back end. This is someone who's got very active allergy and just getting very congested with the nasal cycle. And so for me, her treatments just really, I said, you just start immunotherapy. She's monosensitized. Let's get her started straight away. I actually stopped her using her nasal sprays all the time. I just wanted her to focus on compliance with immunotherapy. And I gave her a regime of using a combination nasal spray just when she got a flare. And then I'm going to review her 3 to 6 months in to discuss a turbinate reduction. If you said to me, why to 3 to 6 months in? Well, I review her 3 to 6 months in. I don't think she'll need a turbinate reduction. I'll tell you why. But 3 to 6 months in, if you look at this chart, this is from the Okamoto study where they looked at the response over time, and really as early as 2 months and definitely by 6 months or 26 weeks, you should see a really clear-cut improvement from being on allergy immunotherapy if you've picked it right. And if you go back and look at her turbinate on the right-hand side compared to my patient who I booked in for surgery almost at the same time as starting his allergy treatment, you can see why I've done that. She doesn't really have turbinate hypertrophy. She's got turbinate congestion. And I must say, as a surgeon, I'm not keen to operate on turbinate congestion. It's not saying I don't, but I'm not keen to initially. I think if you operate turbinate surgery for turbinate congestion, you'll get bitten a few times by patients who have a rhinitis reaction that you're not controlling. Turbinate hypertrophy patients, like on the left, will always love you to some degree. We look at middle and inferior turbinate changes. So this is another study, not, predominantly in children as well, where they talked about this middle turbinate contact. And I think I've sort of brought that home, this idea that when the middle turbinate gets swollen to the point where you lose the middle meatus, that's a great sign. In this study, an odds ratio of 5 to predict allergy. And this inferior meatus, I call it the armpit. Once the armpit goes and you can't see the inferior meatus, like on the black and white slide, whereas what it should look like in a normal nose, that's quite a strong indicator of allergy. And really, this study also looked at these changes in a sort of a regression analysis and showed that the only thing that really confirmed allergy on endoscopic findings, once you adjust for age, gender, pale turbinates, the look of the turbinates, was really these two changes. And you can see them there in a logistic regression analysis. But a really important one for this patient, if this is the sinonasal outcome test I have all patients fill in. When they come and see me, they do it in paper, the first one, and then they do it on a survey monkey after that. And look at her symptoms. Look down the bottom half of the questionnaire. This is the critical one. If you have someone that has lots of what we call right-sided shift in the bottom half of the questionnaire, you'd be very careful that simply just doing surgery on their nose is going to be the answer for them. Fatigue, tiredness, a whole lot of other psychosocial domains are affected. She doesn't think badly about her nose and think that she's got a terrible nose, even though I think as a rhinoplasty surgeon it's not so good. Her main thing is obstruction and blockage. And it's not just her right side that she thinks is worse. This is her, even with her head primed with the idea that I've got a right-sided septal deviation, she really actually only honestly, out in the waiting room, she scores her VAS very, very close as to which side's bad. So you've got to be so careful. I think patients sometimes look at the report of a CT scan and get a feeling very quickly there. So if I'm going to get this lady right, it's not her blockage that we need to get right, it's everything else. And this is the Demoli study here. This is actually only efficacy over a 12-month period on treatment and really shows that you get a benefit from AIT, not just in nasal symptoms, but all those other things, sleep, emotional domains, activities, they all sort of come good to some degree. And so that's the sort of patient in which I'd really want to avoid it. Now you can bet 18-year-old daughter, second opinion, CT scan says something different to what I say. Once I start her on treatment, 2 weeks later, she's going to be calling me about the local reaction and adverse events. And it's really important that you forewarn patients about that, especially anxious ones and anxious parents. Sublingual swelling, so this is someone who sent me a photo, a bit of swelling, itchiness, it's really, really common. And actually local reactions are just a real part of having allergy treatment. I would say if you don't get a local reaction of some sort, then you should almost question whether or not you've picked the right allergen and it's the right treatment for the patient. So although there are studies like this worm study that looked at sort of 8 randomized trial, double-blind placebo-controlled studies with lots of patients to show that they're including with post-market experience is very, very safe. My summary here would be the general advice I would give is that you've got to get a local reaction. If you don't get one, it's almost like a sign that maybe it's not the right treatment. And actually studies that have looked at level 1 ADRs, this was a systematic review in Jackie in practice in 2020, so a very recent study. They actually looked at house dust mite sublingual immunotherapy tablets, a systematic review, and showed that somewhere between 39 and 96% of patients should get some sort of local reaction. But a severe reaction, an anaphylactic reaction that requires adrenaline, is incredibly rare. At least in this systematic review of patients in trials, it's actually less than 0.1%. That's why the advice is you've got to give the first dose in the presence of a doctor, but it's so safe that 1 dose and you can take the rest at home. If you do have a patient that struggles with the local itch, don't get them to take it at nighttime. They often sit there in bed thinking about their itchy throat. Get them to do it in the morning, and they can either pre-dose with an antihistamine the night before or first thing in the morning. And I tell the patients, don't be alarmed if your allergy symptoms generally, not just local reaction from the tablet, but you just general allergy, feel like they're playing up a little bit. They get a little bit more congestion, a little bit more pain. And just be wary, you've got to be careful. The untreated asthmatic, you just want to make sure that you give them maybe a couple of weeks on an inhaler if you think that they might have a bit of brittle asthma. And don't start it during pregnancy. There's no problem to be on it during pregnancy, but you don't want to give someone something that might induce an anaphylactic reaction during pregnancy. That's the only advice there. So in summary, I would say allergic rhinitis is chronic for many people. It's not something that just disappears in their teens and 20s. And so when we meet, especially young adults with turbinate hypertrophy, because they've well and truly established their turbinate hypertrophy by their late teens and 20s, don't see it as being something that's burnt out. The occasional patient, in my opinion, who says, I had a turbinate surgery by so-and-so and it's been fantastic and cured everything, that surgeon, in my opinion, was lucky. He met a patient with turbinate hypertrophy and remodeling, and the natural history of the allergy had already run its course and already burnt out. It's progressive in some, all the way through into their sort of 50s and 60s. It impairs your surgical outcomes. All patients do well 6 to 12 months after surgery. There's this honeymoon phase. Don't try to convince your patients to start their allergy treatment now. The window of opportunity is lost. And the disease-modifying treatment of AIT not only helps the nasal congestion, but it's really a unique opportunity to give them a long-lasting benefit from your intervention. And one thing that I think is true in my practice is that patients often reflect and they say, look, oh, such a good outcome 3 years ago, but they don't see the difference between the allergy treatment and the surgery. They just say, I had surgery with so-and-so and I've been great ever since. That's what their recollection is. When in fact, I actually think 70-80% of the benefit actually came from getting rid of their allergies. My turbinate surgery was just this sort of cherry on the top, of getting their treatment right. Thank you very much. Thanks very much. And all I can say here is that AIT for me has really changed the way that we manage our patients who have turbinate surgery. And now that we don't have to order drops and we've got commercially available oral products, it's really just in the zone, and you don't have to invest. I know Frank, who's been doing allergy treatment for many years, has Di helping him. I've had Raquel, and we started at times of injection and sublingual, but really all my treatments now are through these oral tablets, and the administrative side now of getting patients started is much less. And having starter kits, Allergens I'm sure still offer free starter kits, as many of the companies do. Having these initiation kits means that when the patient sees you for the very first time, you can initiate, give them their turbinate surgery information sheet, dangle it out there, and line them up, to have the whole thing started straight away. And I think having the initiation kit is a big part of that process, being able to start on the day. Thanks very much.